All right, as part B for spine and sacroiliac joint, we'll go through some specific rehabilitation plans. I didn't have a picture, sorry, for sprains and strains. So I guess I can go back. We'll just have this slide in front of us. On your notes there, of course, there's muscles around the vertebrae that can be strained and several ligaments that can be sprained. So the evaluation should help you sort out which one you're working with. However, most of the time it is both. Following the regular rehab guidelines, we need to decrease pain and muscle spasm through the use of modalities and some mild stretching exercises, perhaps using some joint mobilizations or soft tissue mobilizations, aka massage. Correcting posture can be very helpful. Just a note there that supine 90-90, so they're laying on their back with their hips bent to 90 degrees, knees bent to 90 degrees, is commonly the most comfortable position. And interestingly enough, that sometimes people have to be taught that position or shown that position as a place to go when they have a lot of pain for some relief. Once the pain and spasm are under control, we'll begin some strengthening exercises concentrating on the abdominals, obliques, extensors, and glutes. And again, that's just general guidelines. So let's move on to some more specific injuries. Spondylolysis, spondylolisthesis, spondylos, spondylolisthesis, and whatever other words that you want to come up with. So essentially we're talking about a stress fracture in the pars articularis right through here. If we have a bilateral and we begin to have a little shift of the, and here this example is L5 above the sacrum, we get a spondylolisthesis. So most of these conditions are involve the lower lumbar spine and become irritated with extension movements. Patients with these conditions should be taught to maintain, and hopefully you could figure this out, that should be posterior pelvic tilt, as an anterior pelvic tilt would make the situation worse. Hyperextension movements should be avoided, so a person needs to be taught what is hyperextension. What does it feel like to move into hyperextension? Obviously, they should avoid this type of maneuver. And we'll be leaning towards a rehab program called Williams Flexion Exercises. Williams Flexion Exercises will be reviewed in class, but it's a series of exercises that works you obviously into more and more flexion, eventually restoring, moving towards extension though. These patients have to establish and maintain pelvic stability and strengthening of their core. Avoid mobilizations. So there's two things now that you're going to avoid. You're going to avoid hyperextension and you're going to avoid mobilization. We're also going to avoid overstretching. Typically these people are pretty loose in the lumbar spine, so it doesn't help to make them even more mobile. Corsets or braces might be helpful for a short time in order to help control their pain, keep them maybe a little bit out of that extension position. I've seen athletes play with a spondylolisthesis, a diagnosed spondylolisthesis. So they would wear a back support, do exercises following the Williams Flexion exercise protocol, which we'll introduce later. And then just going as symptoms allow. So a spondylolisthesis does not always precludes an athlete from participation. Most of our exercises are going to be done finding pelvic neutral, working on the core, working into flexion. All right, as we move on to disc lesions and sciatica, pain or symptoms down the leg doesn't necessarily mean that there's a disc herniation. However, it's possible. It could be caused by a facet injury. So here's our facet in here. If we have an injury to the facet and the facet actually moves, it could be pinching on the spinal nerve root. We could have muscle spasm around the spinal nerve root. We could have myofascial or connective tissue restriction. Maybe somebody had a previous injury, and as the tissue's healed, it's scarred down, and we have some scarring of the lining around the nerve root as well. So many possibilities. However, somebody with a disc herniation or disc lesion, typically it's in the posterolateral portion of the disc, and so we have a picture here where the disc is herniating posterior into the spinal canal, or if it's more lateral, maybe it's just the spinal nerve root. So in this situation, what we want to do is actually avoid forward bending. So essentially they're the opposite of a spondylolysis. Whereas a spondylolysis will go into flexion, with someone with a disc herniation, we want to avoid that, and we'll go into extension and try to produce a negative vacuum to pull the nucleus pulposus back into the limits of the annulus fibrosus. So patients with disc lesions avoid forward bending and side bending or twisting. So you take a forward bend and add a side bend. That can really cause some problems. We need to teach them how to maintain pelvic neutral. Centralization of pain is good. Centralization of pain is when the symptoms become more central to the spine. So for example, if somebody came in and they had low back pain and they had pain running all the way down their leg, and you gave them some extension exercises, they come back in a week and now they say, well, I don't have pain in my foot anymore, I just have pain in my posterior thigh. Well, that would be a good thing. The pain is centralizing. However, this can be kind of tricky sometimes. A patient might come in and say, well, the first visit I had pain all the way down to my knee, and from my back to my knee, and now I've just got pain in my foot, but I don't have any back pain. Well, that's not centralization. The pain is not migrating more central. It's actually going more peripheralization, and that is a sign that actually things are getting worse. Even if the back pain is getting better, if the symptoms are more peripheral, then we're going the wrong direction. So if somebody has posterior leg pain and they come in after I've seen them and I gave them extension exercises and they say, well, I only have pain down to maybe lower part of my butt, but boy, it's gotten worse in my back. And actually, that's a good thing. As long as we have centralization of symptoms, even if the intensity increases in the back, that's good. Eventually, we'll centralize that pain all the way into the location of the back, and then it'll start to subside. So that's a good thing. The protocol that we'll typically use with somebody with a disc lesion is called the McKenzie extension exercises, and we will review these again at the end of this section and introduce everybody to McKenzie extension exercises. So if the sciatic pain worsens, you need to reevaluate the most recently performed exercises, make sure that they aren't doing them incorrectly, and make sure that you aren't progressing them too quickly. Just a note here that patients who have undergone microdiscectomies start treatment about 1 week post-op, so that means they've removed part of the disc, not the whole thing. And they'll follow a similar course of treatment to a patient who has not had surgical correction. So typically going through the McKenzie extension protocol. So remember, spondies follow the Williams flexion, and the disc lesions or sciatic pain will follow the McKenzie extension exercise protocol. I have a picture here just showing disc movement of the lumbar spine, that when we go into extension, the disc is squeezed together posteriorly, and the annulus fibrosus then is pushed anteriorly. When we go into flexion, the annulus fibrosus is displaced, or the nucleus pulposus is displaced posteriorly, and this is the weakest part of the disc, so we'll often see ruptures or herniations through this posterior lateral portion. Here's an example showing of what's sometimes termed sciatica, where somebody will have symptoms running down their leg. It might be because the piriformis is pushing on the sciatic nerve, In fact, there is, I believe it's 70% of the population where the sciatic nerve comes actually through the piriformis. So spasm or injury or tightness into the piriformis can cause some pain down the leg. We see these nerves coming out of the spinal cord and merging together to form the sciatic nerve. So we could have impingement anywhere on here, or calcification. If we have a stenosis of the foramen where these come out, this can cause sciatic pain. So really, sciatica is just a descriptive of the symptoms and not the cause of what's going on. All right, so going through progression with McKenzie extension exercises, we'll briefly go through this now. Somebody comes in and we'll have them start to lie prone. If they can't lie completely flat, we'll have to start out with pillows under their stomach and work towards a position where they can lay completely prone. Then over a series of several sessions or weeks, we moved them to prone on elbows. Again, we're trying to slowly glide or move that nucleus pulposus anterior away from the spinal nerve root. And as we get closer to that, then we'll go into a press-up position. So that's the progression of those exercises. Facet joints, we have just a little blurb about this. I've kind of addressed this already, but symptoms can be similar to an impingement. It can be similar to a sciatica. They might look like a sprain. But things that you'll typically see are that they'll have pain with motion, and then when they rest, they don't have any pain. They might present with a posture in a side bend or rotation. So cervical area is typically will be locked in the same side as the pain. So if they're the facet joint on the right side of the cervical spine level is bothering them, then they'll be in a right side bend. For the thoracic and lumbar spine, it might be in a side bend either towards the side of the pain or opposite the side of the pain, depending on where the actual problem is, whether it's above or below the nerve root, but it can be either way. So, radiating facet pain can mimic dermatomal distribution into the lower extremity, hence it can sometimes look like a herniated disc. And palpation of specific spinous processes will sometimes cause tenderness, because when you move that spinous process, you also move the facet joint, which can cause more symptoms. So again, we've seen this picture, but we're looking now at the facet joints, not the discs. So as we go into flexion, we open the facet, and if we go into extension, we close the facet. So if somebody has more pain in a localized area in flexion, it could be the facet that is pinched that won't actually open up, or it could be if they have pain with extension in a localized area, it might be that the facet cannot come back in its seated or joint position. There might be a piece of the capsule stuck there, or it might be rotated enough that it's just off a little bit. Treatment for facet impingement, we can see how traction, if we pull apart both facet joints, we might have movement of connective tissue, so that might move out of there, or just maybe even releasing of muscle spasm around the facet joint, so that the facet joint can come back and realign on its own. Joint mobs, so we might be able to kind of manipulate or kind of wiggle that joint back into the position that it should be in. Sometimes there's so much muscle spasm around them that we need to work through that in order to get to a point where we can actually move the facet joint. So those are all certainly possibilities. These are again surrounded by a capsule, so if you sprain a facet joint, we'll be using modalities for a fair amount of time, and the mobilizations and range of motion are going to be very gentle and very slow until those tissues heal up. All right, moving on to the SI joint. The sacroiliac joint can refer pain into the hip or the back. Excessive lumbar lordosis or leg length discrepancy will place a significant additional stress on the SI joint. Causes of SI joint pain, it could be an acute injury, a fall, stepping off of a curb wrong. We see sometimes that this is cyclical for women, so when shortly before menstruation they have a lot of the relaxin hormone dispersed through their body. The ligaments that are tight around this joint, when hormone is circulating, the hormone relaxin is circulating throughout the body, these joints will get more slack. It's all cyclical in preparation if they were going to deliver. And so this is released for a few days until the body kind of figures out, okay, well, if we aren't pregnant, then the relaxin release is no longer continued, and then the joint gets a little more stiff. So it's not unusual to see females come in and they'll say, boy, again, this, it was 3-4 weeks ago I was having problems, and now I'm having problems again. It just seems like it just never gets better. You draw attention to the fact that this may be associated with menstrual cycle, and if that's the case, then we can either change training or just to make them more aware that if we could do less rotation or bending with rotation, it may control their symptoms a little bit better. Treatment for the sacroiliac joint. You can see that there's a lot of ligaments to work through. So if we have any muscle spasm or contraction around there, it's pretty difficult to get movement out of the SI joint. But sometimes we can use stretching to move that, mobilizations. There's something called muscle energy technique. We'll learn some of these techniques in class to move the sacroiliac joint based on attachment of muscles. So if I can take the ilium and I can move the ilium posterior rotation or an anterior rotation, depending on where muscles attach, that might be helpful. Address low back pain and hip areas. So it may be that they have some facet impingement down here, so making sure that we address that. We might have a hip problem. We have to make sure that the hip is cleared as well. Correct the cause to prevent a reoccurrence, symmetrical movement or asymmetrical. So what I mean by that is if somebody continues to have unilateral pain, I'll start talking about, well, when you're standing around, try not to stand just on one leg. Try to stand on both legs. Think about symmetrical movement, whether it's in standing or maybe every time they get out of a chair, they always get out the same way and they'll twist and rotate the same direction. But if they go the other direction, they might not have any problems. So just being aware of things like that. Again, we're going to go over a little mini lab on how to do sacroiliac mobilizations, so you'll become a little bit more familiar with those. The last one on your sheet is thoracic outlet syndrome. And these at first can look like a cervical or a shoulder injury. Typically there's 3 causes for thoracic outlet syndrome pain, which is viewed or seen as heaviness in the arm or the hand, or a tingling down the arm. It seems like it's more global than just a specific 1 or 2 fingers or an area. It seems like the whole arm is affected. But it makes sense when you understand why. The thoracic outlet is this area surrounded in this triangle here, and the brachial plexus comes out through here, and it can get pressed on or impinged in 3 specific areas. So the first one is the area of the first rib. And so if we look on here at this section right here, this is not the first rib, this is the second rib. We need to come more, a little more superior, and this is the first rib here. And if this first rib here is elevated and the brachial plexus has to pull over or get stretched over the first rib, that can cause some neurological symptoms in the upper extremity. The other place could be the pecs. This isn't a great picture, but as the pecs attach across here from the intertubercular groove to the sternum, it can impinge on the brachial plexus. Through here, the pec minor, if it's real tight, can cause some problems as well. And then the scalenes, certainly if the scalenes are tight and they pinch down on the brachial plexus as it comes through this outlet triangle, can cause the same symptoms. So typically the modalities aren't a great help. Posture is more helpful. So getting an upright shoulder back posture tends to take the pressure or strain stretch off of the scalenes. A little cervical retraction can be helpful as well. Here's a picture of our elevated rib, first rib here that I was talking about. Some people do have an extra rib, which we can't do anything about, really. It's not like we're going to go in and take that out. I guess if it were a severe problem, that could be removed. I've never heard of that being done. But here's scalene tightness impinging on the brachial plexus. Posture is a big deal. When we have dropped shoulders, kind of the forward rounded, it puts compression on the nerve and artery. Scar tissue can impinge on that same brachial plexus. So along with posture, we might encourage them to start some thoracic extension. So working through more of the thorax, not so much the cervical, but the thoracic extension movement. Stretching out the pecs. I know it says brachial plexus stretch, but if they're tight in the pectoralis, they're going to feel this through the anterior chest. Corner stretch, supine stretch, brachial plexus stretch. Those are all great options to just slowly stretch out these structures. You have to be careful with the brachial plexus stretch, though. I usually tell patients not to hold it for the 20 to 30 seconds. That's pretty long for a nerve bundle to be stretched out. So I say, just go 5 or 10 and then work your time up. Maybe you eventually get to 10 to 15 seconds, but it's not anything that we're going to change in a short period of time. So being real careful with those. So let's see, if we're on number 5 in your notes, flexibility and strengthening once the inflammation subsides. So pecs, posterior cervical muscles, scalene strengthening, cervical retraction, thoracic extension, chest elevation. Again, we're trying to correct posture and body mechanics. Another thing that's been suggested is breathing instructions. So this starts with the patient laying in supine. I don't know if this is, well, that's not a, but anyway, the patient is laying in supine, and without the pillow, they'll put a hand on their abdomen and a hand on their chest, and they're just asked to practice breathing. And the goal is that they become diaphragmatic breathers, so they breathe from the diaphragm, the stomach muscles, so they should be moving more. So the hand that's on the abdomen should be the one moving, but the one on the chest should be still. And training somebody to breathe like that can reduce the strain in the upper shoulder area and reduce the symptoms of thoracic outlet. This is a picture that was put in last year. People were having some questions about anterior and posterior rotation. So go ahead and look at this. You can become aware of it when we talk in lab. This will probably help make a little bit more sense as far as an anterior-posterior rotation. But we'll review this quite a bit. So that's the end of this section, and we will then see you in class to start going over some of these techniques.